For our second session today, I'd like to introduce you to Dr. Amy Leader and Dr. Veda Giri. Dr. Leader is an associate professor of population science in the Department of Medical Oncology at Thomas Jefferson University and the associate director for community outreach and engagement at the Sidney Kimmel Cancer Center at Jefferson. She's been partnering with Dr. Veda Giri on research related to increasing awareness and uptake of prostate cancer genetic testing for at-risk and underserved population for the past 7 years. Dr. Giri is a professor of medicine at Yale University. She serves as Division Chief of Clinical Cancer Genetics for Yale School of Medicine, Director of the Cancer Genetics and Prevention Program, and Director of the Early Onset Cancer Program at Yale Cancer Center. As a leader of cancer genetics and prevention, Dr. Giri leads a comprehensive effort in genetic evaluation for precision medicine, tailored cancer screening, and hereditary cancer assessment across patient populations. Wow, what amazing experiences Dr. Leader and Dr. Giri are bringing to our lineup for you today. I know I can speak for everyone here when I say we are really looking forward to this discussion on the genetics of prostate cancer. So with that, I will turn things over to both of them.
Thank you very much for having us here today. It's certainly a pleasure to be here to talk about this important and really emerging, rather revolutionary topic of genetic testing for prostate cancer, what you need to know. Dr. Leader and I are very, very excited to be here to talk about this topic from a couple of different aspects. I'll be covering the first part of this presentation and discussion. And the three main things that I'm going to cover are: why is genetic testing important? Who should consider genetic testing? And how can genetic testing be done? What is the process of genetic testing? And then Dr. Leader will be talking about a lot of the work that we've done about extending this basis of knowledge, this context about genetic testing into the community, and how to make this much more accessible and increase engagement for genetic testing across populations. So just to set the stage, we really need to go back to what are the rates of prostate cancer in the United States. It really is a significant public health burden, as we're all aware, with ZERO. And looking at the 2024 estimates, prostate cancer still ranks #1 in terms of estimated new cases of cancer in males in the United States. Skin cancer is still actually #1, but aside from skin cancer, prostate cancer is the #1 cancer, and is also estimated to be the second leading cause of cancer-related deaths in U.S. males, accounting for over 35,000 males estimated to die from prostate cancer in 2024. So a major, significant public health burden. Overall, 1 in 7 men will be diagnosed with prostate cancer in the United States. 1 in 5 Black men will be diagnosed with prostate cancer in their lifetime, so higher rates in Black men. And really important to keep in mind that when we're thinking about genetics, in particular for the purpose of this topic, that there's over 3 million prostate cancer survivors in the United States, many of whom would qualify for genetic testing, and we'll talk about what that means in just a moment. Importantly, about 5 to 10% of prostate cancer can be inherited. So it's not the majority of prostate cancer, but it's important to keep in mind that while prostate cancer is such a major cancer among males in the United States, this actually represents a substantial proportion of those individuals who could have an inherited predisposition to prostate cancer. So just to quickly review, this may be very familiar to many people who are listening, but I think it's always important to set the stage with what is the prostate, what is prostate cancer screening, and then differentiate that from genetic testing. So what is the prostate? The prostate is a walnut-sized gland that is located at the base of the bladder. This is a cross-section through the human body. So this is the bladder up here. This is the prostate gland sitting just below the urinary bladder. And you can see that the urethra passes right through from the bladder through the prostate and out. The main function of the prostate gland is to secrete a fluid, which is a component of semen. And one of the things to note here is that the prostate is buried very deeply in the pelvis. It is in front of the rectum. And this is where one of the screening approaches for the rectal exam becomes important with a digital rectal exam to feel just the back of the prostate for any irregularities. So what are some symptoms of prostate issues? Males who go to the doctors maybe ask some of these questions. about having to urinate more than usual, especially at nighttime, difficulty having or keeping an erection, blood in the urine or semen, pain during ejaculation. Why are they asking these questions? It's mostly just to think about, could there be an issue with the prostate that needs to be explored? Because having symptoms such as these does not definitively mean that a person has cancer, prostate cancer, but it should be noted and addressed. An enlarged prostate or some of these symptoms could be due to enlarged prostate, but other conditions as well, like diabetes or heart disease, can cause some of these symptoms. And the thing to keep in mind is the reason for screening to be done is to catch a cancer at a curable point before symptoms develop. And so therefore, with prostate cancer, there could be no symptoms, and that's why screening is important to consider. But if any male has any of these symptoms, really any individual, they should bring these symptoms to the attention of their doctor. So when we think about prostate cancer-related tests, it's important to differentiate different tests related to prostate cancer. So what are screening tests? What are tests for diagnosis of prostate cancer? And our purpose of the discussion today being genetic tests. So screening tests are those tests that are used to help determine suspicion for prostate cancer. These are tests like the PSA test, and part of the approach that goes hand in hand is the digital rectal examination. So the PSA test is different than a genetic test. And this does not diagnose cancer. It helps to determine the suspicion for prostate cancer. Diagnosis of prostate cancer is done by a prostate biopsy. So this is where an ultrasound-guided probe is inserted into the rectum, and a needle is then deployed into the prostate to be able to sample pieces of prostate tissue. And a lot of this is guided to look for areas of concern in the prostate, and some of it is random biopsies. These pieces are looked at under the microscope to look for areas that look like cancer. So the biopsy is the approach to help diagnose prostate cancer. Genetics is a whole separate type of testing. And what we're talking about here is hereditary cancer genetic testing. Here, the purpose is to identify risk for prostate cancer, risk for other cancers, inform treatment and screening, and give information about hereditary cancer risk in families. So this is typically done on a blood or a saliva sample, and there are various different kinds of genetic or genomic tests. So it's really important to talk with your doctor about what are the different genomic tests that may be done if a person has a prostate cancer diagnosis, because they can be different. Here, we're going to be talking about hereditary cancer genetic tests. So once a prostate biopsy is done, if there's been suspicion for cancer, and the tissue is looked at under the microscope, there's different factors that are then used to help characterize that the diagnosis of prostate cancer, as well as extent and behavior of that prostate cancer. Gleason score grade group is the way that the cells look under the microscope. Do they look well differentiated? Like, they look very much like original prostate cells. Or has there been sort of a destruction of the prostate architecture, in which case there could be sheets of cells, loss of the ducts. So they look poorly differentiated. So this leads to a higher Gleason score if they do not look like original prostate tissue. So there's a primary and a secondary Gleason score, but now the more updated way of looking at this is grade group. And so the higher the grade group, the higher the Gleason score, the more aggressive the cells look under the microscope for characterizing that prostate cancer. Stage is another important piece of information, and I bring these pieces up when we're going to be talking about genetic testing, because these are two of the factors that are really important to consider if a male is eligible for genetic testing. So stage becomes really important, of course, from the treatment aspect, as well as the context of our discussion today for genetic testing. So stages are, confined to the prostate, being stage 1, small focus of tumor confined to one lobe of the prostate. Stage 2 being in multiple lobes of the prostate. Stage 3, where the cancer has extended outside of the prostate, for example, to the seminal vesicle. And stage 4, which is more extensive spread. So from the prostate out into the seminal vesicles, out into lymph nodes, and disseminated usually to bone or other organs in the body. That's considered metastatic prostate cancer. So we're going to put all of this together now and think about this in the context of genetic testing. It really has become a revolution in prostate cancer care to think about genetic testing. It's impacting metastatic disease treatment significantly in terms of targeted therapies that can be targeted or used specifically in individuals that have specific genetic mutations. And on the screening side as well, to think about advanced screening approaches, earlier initiation of screening for individuals who carry specific genetic mutations. It's also in evolution, not fully in practice, but a lot more data is coming forward about how can we think about genetic information in the context of active surveillance as well. And across the board, the information from genetic testing gives us clues about hereditary cancers in families. So this is important whether we're looking at it from the metastatic setting or all the way to the screening setting. So let's talk a little bit about understanding genetic testing. What is the purpose of genetic testing? So some key takeaways to keep in mind as we proceed through the next few slides are that really genetic testing, this is hereditary cancer genetic testing, is to look for inherited genetic mutations. It is to help understand cancer risks for you and for your family. The information gleaned from the genetic testing can help provide cancer risk information, as well as thinking about how that risk information can be used to screen better for a host of cancers, and then provide information on how best to treat prostate cancer, particularly in the metastatic setting, as I mentioned. So this takes us back to Genetics 101 to think about some of the basics of cancer genetics. As I mentioned, about 5 to 10% of prostate cancer is inherited. And when we think about genetics, we're talking about genes. So what really are genes, and what are we really testing when we talk about genetic testing? So genes are pieces of DNA that operate the cells of our bodies. They are the operators of our cells. They tell our cells when to grow, when to die. They send the signals to our cells. Genes are, we have 2 copies of our genes, one from our mother and one from our father. And genetic changes actually determine a whole host of characteristics for us. Some of them are physical characteristics, eye color, hair color, and some of the genetic changes like genetic mutations or pathogenic variants, which is the more sort of updated nomenclature. But I'm going to go back and forth and say mutation or pathogenic variant. So mutations in genes can also impact our risk for diseases such as cancer. So one of the things that's really critical is knowledge of family history to the best that a person knows that information. Why is because genes can be linked to various cancers in families. So for prostate cancer, when we're talking specifically about genetic testing for prostate cancer, there's some specific features to think about in that family history. So to know whether any family members had metastatic prostate cancer or ended up dying from prostate cancer could be really helpful information. Thinking about all male relatives on both sides of the family, if they had any cancers, ensuring that we cover, males on the father's side of the family, males on the mother's side of the family. So when we think about family history, we want to think about both sides of the family, go up to the grandparents' generation and down into the children's and, cousins as well. So kind of broader family history can be really important. It is important to think about females in the family as well, such that, males may tend to just think about cancers in males, females may tend to just think about cancers in females, but it is really important to ensure that everyone is thinking about cancers across the board for all blood relatives, because cancers, again, can be connected. For example, prostate cancer could be connected also to a family history of breast cancer or ovarian cancer. And then even more broad family history, thinking about cancers like pancreatic cancer, colon cancer, uterine cancer, melanoma, all of these cancers in family members, blood relatives, is important family history to know. Now, one of the things that we do hear a lot is that it's hard to know that information about family history. Cancer may not always be discussed in families. There may be estrangement from relatives or one side of the family. A person may be adopted. So it's really just knowing the information to the best that we can to bring that forward to help in decision-making for genetic testing. There are several genes that are very important in terms of genetic testing for prostate cancer. And I'll run through a couple of these in just a moment. Actually, they should say BRCA1, BRCA2. Sorry that got cut off. And those are some of the critical genes, particularly BRCA2 in prostate cancer genetics. Multiple other genes are shown here in terms of thinking of a set of genes for genetic testing. So then what are we really doing when we're doing genetic testing? Genetic testing is performed to identify genetic mutations or pathogenic variants, which are changes in the genes that can lead to diseases such as cancer. Now, if you think about a gene as a word in the English language, you can think about it as words carry meaning, genes carry signals. Genes have a code. They have a genetic code, and words have a spelling. And so if you change the spelling of the word, you can completely change the meaning of the word. For example, tree to free, that completely changes the meaning of the word with a one-letter substitution. The same thing can happen in a gene. You substitute part of the genetic code, can completely change the signal that goes out to the cell. Or it can render it nonsense. So for example, tree, T-R-E-E to T-X-E-E, that has no meaning. The same thing can happen with a genetic mutation. So it can stop a signal from going out where a signal is meant to go out from a particular gene. So these are some of the things that are being looked for in genetic testing, in looking at the genetic code. So when we talk about hereditary cancer genetic testing, we're talking about testing being performed on a blood or saliva sample. The sample is sent to a qualified clinical genetic testing laboratory to perform the genetic testing. And the results are then sent back to the ordering doctor or the genetics provider to discuss the results with their patients. So that brings to mind one thing I just want to bring up just before talking about the BRCA genes is that, it is really important to have this genetic testing in the context of a trained professional and to think about the laboratory that has the clinical experience to do comprehensive genetic testing. We want to ensure that, the testing isn't being done by an inexperienced laboratory or that it's incomplete. So just to review at a very high level, what are some of the key genes important in prostate cancer? Two of the key genes, and one of these in particular, BRCA2, is really, really important in prostate cancer risk and in treatment. So BRCA genes are linked with a higher risk of prostate cancer. BRCA2 mutations in particular are associated with risk for aggressive prostate cancer. The cancer risks for males who may have a inherited BRCA2 mutation or BRCA1 mutation include risks for prostate cancer, male breast cancer, pancreatic cancer, and melanoma. For females, the risks are female breast cancer, ovarian cancer, pancreatic cancer, and melanoma. And again, really important to think of males and females because of the hereditary nature of these genes. HOXB13 was the first hereditary prostate cancer gene identified. And so this right now, it really is associated with higher risk of prostate cancer. This is associated with hereditary prostate cancer in families. And a lot of data has also linked HOXB13 mutations with younger age of diagnosis of prostate cancer, such as for males even in their 40s. And then genes linked with Lynch syndrome also could raise the risk for prostate cancer. These genes are shown here. Lynch syndrome is actually a hereditary colon cancer syndrome and is linked with many other cancers as well. And prostate cancer can be a part of this syndrome. So there's a higher risk of prostate cancer, as well as higher risk for a host of cancers as shown here. Colon cancer in particular, uterine cancer for females, pancreatic cancer, ovarian cancer for females, other upper bowel cancers, urinary tract, brain, and skin cancers. So if a genetic mutation is found in a gene linked with Lynch syndrome, you can see that a lot of cancer screening would be necessary in a very comprehensive manner. So then who is eligible for genetic testing? Really, we can break this down in a couple of different ways. This is sort of a simplified version of the national guidelines for who is eligible for genetic testing or who should be considering genetic testing. Men with a strong family history of cancers. This just goes back to exactly what we were talking about for the hereditary nature of testing, as well as knowing family history. So prostate cancer in male relatives at young ages or with a history of metastatic prostate cancer or family history of multiple other cancers that could be connected. Men with who themselves have metastatic prostate cancer, because the metastatic setting is where there's been the highest rates of genetic mutations identified. So men with metastatic prostate cancer or even with lymph node positive prostate cancer really should consider genetic testing of their own. Men with advanced prostate cancer, this goes back to thinking of higher Gleason score or grade group, higher stage, men who had a higher PSA at diagnosis of over 20, indicating that maybe this was more of an aggressive prostate cancer at diagnosis, and certainly men with a known genetic mutation in the family to have their own genetic testing to see if they could have inherited this genetic mutation. So this genetic testing, as I mentioned, really should be done in the context of a genetics professional. A key professional group are genetic counselors. So what is genetic counseling? Genetic counseling is this process of undergoing genetic evaluation by genetic counselors. Genetic counselors are trained professionals in this field of genetics, genetic testing, and they help discuss the benefits and potential risks of genetic testing so that patients can make an informed decision about genetic testing. They discuss options for genetic testing with patients, review the results, and go over full recommendations, as well as coordinate genetic testing for family members. I'm not going to review necessarily all of this, but I wanted to show that the genetic evaluation process can be multi-step, and genetic counselors help guide individuals through this process of, after an appointment is made with a genetic counselor, completing and helping individuals determine the full family history to help guide genetic testing, discuss many important elements about genetic testing so that an individual can make an informed decision about genetic testing, discuss what are the different options for genetic tests, and then once the testing is done and the results return, go over the results with patients in the context of their genetic results, their family history, and making sure that this becomes a part of their care overall. There's different types of genetic tests or extent of genetic tests, which is important to discuss with patients. Some genetic tests are very focused panels, such as just a few set of genes that really could be related to a known mutation in the family or based on family history. There can be cancer-specific panels, such as a prostate cancer panel, so genes that have higher evidence for association to prostate cancer, or even larger cancer panels where there can be genes associated with the cancer of concern, but also a host of other cancers that are somewhat more common in the population, and even genes associated with early evidence for association with cancers. So it's just important to understand what are the considerations with these various panels. What are the rates of uncertain findings when you go from smaller panels to bigger panels? And what are the guidelines associated? Can anything be done if information is found in, say, a preliminary evidence gene? So when we think about what are the benefits of genetic testing, these are some of the important benefits to think about: identifying risk for prostate cancer for an individual or their family, learning about information for other cancer risks as well, to help guide decisions for prostate cancer screening, or if a person has a diagnosis of prostate cancer, particularly metastatic disease, guide decisions for treatment of prostate cancer as well, guide decisions for screening of additional cancer risks that could have been identified, and then help to identify those cancer risks in blood relatives for their own screening and prevention. But what are some considerations or possible risks for genetic testing? It doesn't always provide an answer about why a person has a cancer or there are cancers in the family. Oftentimes the results come back, indeterminate or inconclusive for why the cancers are occurring. There can be uncertain genetic test results, variants of uncertain significance, meaning it's just not clear if a genetic change is a mutation or just a silent benign change. And this can cause some level of anxiety for patients, though these uncertain findings don't impact management at the time that they are reported. Some genes tested may not have enough information to help make a decision for treatment or screening. And so it's more sort of academic, it's just information in case in the future there's more guidelines associated with some of that. An important thing to keep in mind is the GINA law. So this is the Genetic Information Non-Discrimination Act. And it's a law that helps think about where are there protections for individuals that may have a genetic mutation from various insurance aspects. So the GINA law protects many health insurance companies and employers from using a genetic test to discriminate from health insurance or from employment. Now, there are some loopholes and it doesn't give full coverage, but for the most part, that is covered. But the law does not apply to health insurance through U.S. Military, Veterans Administration, Indian Health, or federal employees' health benefits plans. And also important, so these individuals who have these plans need to check with their insurances as well. The law also does not apply to small businesses with less than 15 employees. But what is really important is that it does not apply for life insurance, disability plans, and long-term care insurance. So anyone who is otherwise healthy, who is thinking about genetic testing, really should make sure that, have they given these things consideration in terms of things like life insurance, and, get those things in place before proceeding with genetic testing. If it's an issue, and so it's just important to consider these in the process of making a decision for genetic testing. And genetic tests may not identify all genetic mutations. They're very good these days. For the most part, with the testing techniques at an experienced laboratory, we can identify mutations, over 90–95%. But there are some gaps in coverage in some of the genes. And so it's just important to keep that in mind. So as we think about this from the standpoint of where is the impact on care, and this will be the sort of final few slides, is for a male that has metastatic prostate cancer, who may, for example, have a BRCA2 mutation identified on genetic testing. There are multiple targeted therapies. These are called PARP inhibitors that can target or be used specifically in those individuals that have a BRCA2 mutation, to help improve clinical outcomes in the treatment of metastatic prostate cancer. This is typically done in a specific sequence along with existing well-established therapies. On the side of screening, for example, a male with a BRCA2 mutation who doesn't have a prostate cancer diagnosis would be recommended to start prostate cancer screening at the age of 40. So this is younger than in the general population for recommendations for initiating prostate cancer screening. And there are clinical trials that are going on looking at the role of MRI, for example, in addition to PSA, digital rectal exam, for enhancing screening approaches. And there's growing evidence in support of MRI as well. So we're going to see this field evolve in terms of thinking of ways to enhance screening as well. And as I mentioned, from the hereditary aspect. So in conclusion, for my part of the presentation, is that genetic test results are really important to help inform prostate cancer treatment and screening. Additional cancer risks can be identified and need to be addressed. Very important is that this is hereditary cancer testing, and hereditary cancers can be identified in the family so that family members may need their own genetic testing. Family history is really critical, and we just need to know the information that can be learned about the family history to explore cancer risk. And seeing a genetics professional, genetic counselor, physicians, or clinical team members who are experienced and trained in genetics is really crucial in making informed decisions for genetic testing. So thank you again for the time in talking to you about genetic testing for prostate cancer. And I will turn it over to Dr. Leader for the second part of the presentation.
Excellent. Thank you, Dr. Giri. That was wonderful. So always so nice to hear the strong foundation of prostate cancer and genetic testing. And so I'm going to wrap up this presentation today, talking about identifying and overcoming barriers to prostate cancer genetic testing. And we know that just because the science is there and the tests are available, that they're not equally available to all. And I think one of the things that Dr. Giri and I are very passionate about is trying to reduce disparities, to certainly not create new disparities by new science and new technology, and ensuring that everyone has access to these really powerful tools to manage their health. So I'm going to talk a little bit about some of the barriers to prostate cancer genetic testing, a national roundtable that we convened just about this time last year, and some of the findings from that roundtable work. So next slide, please. And so we know that all of the wonderful science that Dr. Giri just showed us is not without fault. We know that men in general sometimes have low levels of knowledge about prostate cancer, about risk factors, about screening. There's some confusion about when to be screened, what are the screening types, and definitely about genetic testing and genetic testing options. And Dr. Giri and I have a long line of research about helping men understand what is genetic testing, what isn't genetic testing, when it's important, when it's appropriate, and all of these kinds of things, because we know about the low levels of knowledge. And there's also there's negative beliefs in communities about the importance of cancer screening, and particularly around genetic testing, whether these tests are are important, whether they work well, and low uptake of these tests have definitely hampered efforts to increase screening and testing among eligible males. And then these kinds of disparities, they just continue to propagate, and they will impact treatment, and they will impact outcomes, and they will impact long-term health for men, particularly for Black males, which is what we're going to focus in on the next piece. Next slide, please. So I'm going to share with you the work that we did on a national roundtable. But I first wanted to tell you about the socio-ecological model and introduce this to you if you haven't experienced or seen this kind of a model before. So the socio-ecological model is a planning model that's used largely in the public health community and other areas of healthcare to organize or categorize different kinds of barriers or factors that might be impacting a health topic. And so we can think about things like barriers or factors at an individual level, which might be someone's knowledge or their attitudes or their beliefs. And then you can also think about how they interact with others and those kinds of barriers at an interpersonal level. The next layer out is an organizational level. What are institutional level barriers or factors that might be impacting a health problem? Going out to the community levels, more like media, organizations, societal factors, communities, and what are those barriers that might be impacting the health problem? And then lastly, there's a policy level on that outermost ring, and there are, we can think about how factors at policies, big policies, little policies, whether they're bills or laws, or they're just policies within insurance and otherwise that might be impacting, in our case, access to prostate cancer genetic testing. But you can think about this widely across health problems. So the socioecological model is used in many different topics in many different areas, and we thought it would be a really nice model to organize our thoughts around the National Roundtable. Next slide, please. And so as I was mentioning, Dr. Giri and I convened a roundtable just about this time last year, where we specifically invited key stakeholders. And in this case, it was 23 of them. They were invited to participate in a 2-day online consensus conference to talk about barriers and solutions to increasing uptake of prostate cancer genetic testing, specifically in this case, among Black men. We know that Dr. Giri shared the data on prostate cancer disparities in Black men, and we know that the uptake of genetic testing in Black men is low. So when you put those two things together, there's a real need to understand the barriers and the opportunities. We invited a mix of clinicians, researchers, genetic counselors. Dr. Giri explained what genetic counselors are, but as well as patients, advocates, survivors, caregivers. So this was not merely a professional audience. This was a mixed audience from multiple perspectives. We started out our time by listening to a series of presentations about prostate cancer, genetic testing, similar to like what Dr. Giri shared with us, but other kinds of talks like that just gave us the science and the evidence to have our discussion. And it was all tailored to the Black male community and their needs. And then after we went through all of these evidence-based presentations, we divided ourselves into 2 groups and we asked a single question. What are the barriers and opportunities to increase prostate cancer genetic testing in the Black male community? And we thought about it through the lens of that socio-ecological model. So we talked about individual level and interpersonal level. We talked about institutional levels, community levels, policy level. We did them one by one. We held those 2 groups simultaneously at the same time, and they were moderated by Black men, Chris Bennett, who you might know from his work at the ZERO community here, and Terry Fortune is another one of our colleagues who we worked with for a long time, a very active Black male in health issues in Philadelphia. So it was not Dr. Giri and I, we were listening, but we had lovely moderators for our discussions, and as I mentioned, we used our socio-ecological model to organize all of our discussions. Next slide, please. And so again, we had these 2 groups, and this was the single question that was posed to us. What are the barriers and opportunities to increase prostate cancer genetic testing among Black men? Next slide, please. And I'm going to share with you our overarching findings. So what we did is we recorded all of these discussions that we had. We had these two groups going simultaneously. We recorded the whole thing. We transcribed them. And then Dr. Giri and I went through and we coded them and we pulled out all of the key themes related to each of the levels. And I'm just going to share with you a snapshot of what we found. Dr. Giri has submitted this for publication. We're awaiting those results, but you'll be able to read that far more in depth, but in the limited amount of time, I just want to share with you sort of some overarching findings. So the group, the 23 of us, talked about barriers and opportunities at these different levels. For this cases, I sort of put together individual and interpersonal level, but you can see the barriers we talked about were a lack of awareness among men, lack of trust in the healthcare system, and a little bit in the genetic testing itself. There was a nice discussion about male cultures just being like, I'm healthy and I don't need this for me. I'm going to keep going. I'm working, I'm providing for my family, and I just got to keep going. There was also the mentality of, I don't really want to know. If I do this, it's going to open potentially a whole new can of worms of things I'm going to have to deal with right now. And I just can't take this on. There were discussions about the concerns of the cost of the test and the implications of the findings. So what does this mean for my own healthcare? What does this mean for my children? Am I burdening my family if I share that I'm at high risk for a genetic mutation, or I have a genetic mutation? What does that mean for my adult children? What does that mean for my spouse who might have to care for me? Like there was just a lot of discussion there. But then we also talked about opportunities, and we talked about normalizing the conversation among men themselves, among Black men, also within families, within communities, within the groups that they talk with, and just saying that, not only is prostate screening important and normal and something you should be doing, but if you are eligible, then as should prostate cancer genetic testing. These just need to become parts of normal conversations. We talked about personalizing messages a little bit to address specific concerns. Maybe it's about cost, maybe it's about male culture, that idea of preferring not to know, helping men get over that, and really trying to narrow in on some of these issues and barriers that came up with real targeted messages. And on an interpersonal level, we know Dr. Giri and I have done work with peer-based approaches. So having open and honest discussions with men who can really sit down and say, I know what you're going through. I understand. I have the same concerns. I went through it. This is what happened to me. So a little bit of a combination here. And I'll share with you what we talked about at the institutional level. So remember, the institutional level is like health systems, hospitals, doctors' offices, clinicians, not the individuals anymore, but sort of up a level. And some of the professionals in our group noted that there's a lack of a centralized pathway to order prostate cancer genetic testing. And as a patient, you might not experience this, but behind the scenes, it's not as easy and straightforward as one might think to order this in your healthcare system. And so making it easier for professionals to do that will also reduce barriers. There were discussions that the guidelines can be confusing to doctors who need to order testing. If you're a primary care doctor, but you recognize that your patient may be eligible for genetic testing, but you're not used to ordering it, or thinking about who's eligible, those guidelines can be confusing, and there may be missed opportunities there for who's being offered testing. And the professionals and some of the patients noted that the cost of testing should not be a barrier anymore. It should be covered by institutions, other fundings, that there are ways to overcome cost issues. And then on the flip side, when we talked about opportunities, we talked a lot about workforce diversity. It gets a little bit back to that interpersonal level of having men see other men who are like them, who are either offering them genetic testing, who are maybe the genetic counselors themselves, who are helping them through the results and the discussions about it. When people see others who look like them, then there's much more comfort there. We talked about continuing education for the doctors to understand genetic testing, not only the guidelines, but we talked about streamlining the processes in health systems and hospitals to order the genetic testing, and then reducing the cost barrier. Institutional funding, other funding, whatever it is, that cost really shouldn't be an issue here for people who need it. Next slide, please. We moved out a level and we talked about the community level. This is things like media, societal groups, just sort of that web of people outside of your family. And the number one barrier that the groups came up with was around media attention. And we had a lot of discussion that women have done a really nice job in promoting breast cancer screening, breast cancer awareness, breast cancer genetic testing. Women know which genes they have. They understand which genes are important. The word BRCA and BRCA genes have become almost normal among women and in women's health discussions, but that's not the case among men and prostate cancer genetic testing. That was our number one barrier that we talked about, and opportunities there were things like simplifying the message. And genetics and what Dr. Giri went through it can be very confusing. There's a lot of genes, there's a lot of pathways, there's a lot of risk factors and things to think about. But just creating a very simple message that men can understand, and that they can sort of grasp onto and sort of go with and run with, as well as putting these simple messages in media channels and outlets that men listen to and watch. So there's a lot of discussion among the men of things like, during commercials during football season or baseball season or barbershops and things like that, getting the messages out there. Offering health workshops in community settings, like barbershops, like at baseball games, like all the places that men like to hang out, offering health workshops there. And then in doing so, partnering with trusted organizations in the community. Maybe it's their churches, maybe it's the men's groups, the Mason groups, the fraternity, alumni groups. Those trusted organizations, even if they're not health related, can really help us in the healthcare world build trust and expand our reach. Next slide, please. And we ended on policy. And so this is sort of that outermost ring in the socio-ecological model. Again, the cost of testing came up, but this time in a policy perspective. So not thinking about the individual cost to men, but why aren't there laws and legislation that just take this cost issue right off the table? Why are we still dealing with this? And then there were also concerns about the implication of abnormal results or some indication of increased risk, thinking about life insurance policies and what that means and being covered. Men were concerned about being dropped from either health policies, life policies, work issues. When you're known to be at increased risk for something, you have to walk a little bit of a finer line there. And that shouldn't be the case. This should be open to everyone, without any kind of penalty or implication of what the result is. And some of the opportunities here, again, at a policy level, we're working with insurance companies to ensure that genetic testing is affordable, benefits are protected, was the overarching result there. The health professionals were concerned and wanted to really make a point about formalizing guidelines for BRCA2 positive men and those for low risk of prostate cancer. Something that the professionals brought up, but they felt that this could be addressed by policy, and it would make things smoother on their end for knowing who's eligible for testing and then ordering that testing as well. And they also, again, the professionals, but it was backed by the patients, that there really should be less emphasis on family history in guidelines, because as Dr. Giri alluded to earlier on, a lot of people don't know their family history. They're unsure about it. They're uncertain about asking family members about it. And so having a less emphasis on some of these softer things like family guidelines would make things easier. And next slide, I think, is a summary. And so we know that the barriers to prostate cancer genetic testing exist. We know they exist at multiple levels. I just went through them with you, what we learned at our roundtable. And they do contribute to the low rates of testing, particularly among Black men, which then ultimately contribute to health disparities down the line because men aren't receiving the same level of care and having the same opportunities as others. We learned that having multiple perspectives at the table, when we had patients mixed with providers and caregivers, and some researchers in there, really, I think, added to the depth and the breadth of our conversation. And we came up with a lot of additional challenges and barriers, as well as opportunities, that if we had just had a group of doctors at a table or a group of researchers or even just a group of patients, I think by mixing everyone together, we really increased the scope of our analysis there. And just like we identified multiple barriers, we know that there will be opportunities at multiple levels and they need to come together. And so when we can think about sort of multi-level interventions or multi-layered opportunities to simultaneously address these barriers, I think we'll all do better in the long run. And I think we'll also be able to provide some additional actionable health information to family members and to hopefully reduce disparities in the end, which is our ultimate goal here. And I think, Dr. Gary, I think that's my last slide. And I thank you for the time. Thanks to Zero for having us.